Okay, ladies and gentlemen, here we are. This is attempt number 8, attempt number 9. I am losing count, but I am trying to deliver a better version of a PowerPoint than my last PowerPoint. I understand last time that there were many difficulties with accessing PowerPoint and the fact that you had to hit on every slide in order to hear my voice and the voiceover. So hopefully I am able to correct that with this PowerPoint and be able to deliver a better product. This is my last lecture of the semester, and if my reputation has preceded me, then you are aware that I always get a little weepy at the last lecture because it is the end and, I'm sending you off for a little bit and will not be with you. And today is a little extra weepy because I was out at campus today with Professor Thieler, and we were packing up the office because over the summer our building will be made brand new. So hopefully when we come back in September, everything will be clean and fresh and brand new and ready for us to have a clean start. Not only us, but you as well. So today we are talking about connective tissue disorders. And upon completion of this class, you will be able to summarize the pathophysiology of the more common connective tissue disorders. You will be able to differentiate the abnormal assessments from clients with connective tissue disorders to a normal assessment, or what we consider an assessment within normal limits. We will identify the diagnostic studies associated with connective tissue disorders. We will judge the appropriateness and safety of administering the more common medications used for the treatment of connective tissue disorders. And we will evaluate the needs of clients with connective tissue disorders and their families. Their families are going to be very, very important in patients and clients with connective tissue disorders, because these disorders, there is no cure. There is no cure. We can't fix them. We can prevent further damage, and we can manage the disorder, but we cannot make the disorder go away. So education for the client and education for the client's family is so very, very important. And we will formulate a plan of care for a client with a connective tissue disorder. We will look at the alteration or disruption of the proper function of connective tissues within the body. Connective tissue is made up of collagen and reticular fibers, and these fibers are composed of collagen and elastin. And elastin is what gives the muscle that give. It gives the muscle the ability to stretch and bend. Connective tissue forms a matrix that will cover, support, and protect structures and organs and aid in movement. So in connective tissue disease, the collagen and the elastin are damaged by inflammation or immune system dysfunction. So some examples of connective tissue are bone, cartilage, tendons, ligaments, lymphatic tissue, and bone marrow. Rheumatic disorders are commonly called arthritis or inflammation of the joint. We have done something to piss off the joint, make the joint angry, and the joint does not want to cooperate and work as well. It will affect both males and females. Some rheumatic disorders will occur at any age, and these are the rheumatic disorders. And then some will occur most often at certain ages, perhaps later in life, and these are the osteoarthritises. So basic classifications: if the rheumatic disorder affects one joint, it is called monoarticular. So therefore, if it affects multiple joints, it is called polyarticular. And then we have inflammatory versus non-inflammatory. So inflammatory would be RA, which is rheumatic arthritis. And then non-inflammatory, it would be OA, and that is osteoarthritis. So pathophysiology. The general pathophysiology includes changes in the joints and or the connective tissue. So damage to the joint occurs as a response to an inflammatory process. Remember I said that the joint is angry, the joint is pissed off over something. So primary rheumatic disorders, the problem is the immune system's inflammatory response. However, degenerative rheumatic disorders is when inflammation is a secondary response. So, for instance, in degenerative joint disease, which most older adults in some or one joint or another, you will always see degenerative joint disease. Spine, knees, back. You will always see this noted on an x-ray, perhaps when you're looking in the clinical field and you're looking at your client's x-rays. You will see, somewhere along the way that the radiologist said degenerative joint disease. So that in itself is very common. However, inflammation in someone who has degenerative joint disease, this inflammation is a secondary response. It is not the primary disorder. So in rheumatic disorders are a type 3 hypersensitivity immune disorder. Remember back when we were talking about allergic disorders and we were talking about hypersensitivities. Well, rheumatic disorders fall in classification 3. They are a type 3 hypersensitivity immune disorder. And this is all about the inflammatory process going wrong. It is an inappropriate response to an invasion or a foreign agent. So therefore, it involves a trigger. There's going to be a trigger, just like in the allergic response. There's going to be a trigger or an antigen, and then there is going to be a series of related steps. So the inflammatory process, it can involve joints, as in lupus and RA, rheumatoid arthritis, and then the skeletal muscle, bones, which would be osteoarthritis, ligaments, tendons for spondylitis, connective tissue, the vascular system, and then the skin, as in scleroderma. So some common signs and symptoms would be chronic inflammation, the joint is angry, it's pissed off. There's going to be pain, your client is going to complain of some pain. Limitation of movement, where they are not going to be able to flex, bend, they will not have proper range of motion. And then there will be structural changes or degeneration. And again, these are things that you will see on an x-ray, these structural changes. So the common disorders are rheumatoid arthritis, RA, lupus, scleroderma. These are all the ones that we are going to be talking about today, in addition to osteoarthritis, and then there is vasculitis. So with rheumatic disorders, the onset may be acute or it may be insidious. Treatment may be very simple, such as relieving localized symptoms, or it can be more complex. And this is when the disorder becomes more systemic. So rheumatoid arthritis, the exact etiology is unclear. However, genetics and environmental factors are thought to play a key role in the development of the disease. And if you have a first-degree relative with RA, rheumatoid arthritis, you are 1.5 times at a higher risk than the general population. So this tells me that it lives in families. It will travel in families. So mom might have it, dad might have it, you might develop it later in life. Maybe you have aunts, uncles that also have it. It will travel in families. Females are 2.5 times more likely to be affected than males. And onset is most common in the 3rd to 5th decade. So sometime between the 30s and the 50s is when we are going to start to hear these complaints, or your client will present with clinical manifestations. So some environmental factors that will initiate the development of the disease are cigarette smoke, bacteria, and then viruses. Some clinical manifestations that we are going to see is your client will complain of joint pain, knee pain, ankle pain. You might notice some swelling. One joint may be a little bit more swollen than the other when you're comparing from side to side when you're doing your assessment. There may be some erythema, which is redness of the skin due to the inflammation. So not only will it be angry on the inside where the joint is, but we will see some of that anger in the redness of the joint on the skin. There will be some morning stiffness. Your client will complain of fatigue. And onset is rapid. Now, when I'm saying onset is rapid, I'm not talking minutes to days. I am talking a longer period that ordinarily you may think is gradual, but it is not. It will be rapid. For instance, if you see a client in September and she is saying that she's having trouble getting up in the morning, she's feeling a little stiff, it's taking her a little bit of time to get ready for work, and when she's at work, she may be a little tired. By the time she gets home, she's having dinner, and then she just wants to go to bed. But then if you see this client a couple of months later, perhaps in December, in January, and now she's in the office and she's telling you, before I could get up an hour. An hour for me to get ready for work was plenty. Now I have to get up 2 hours because I'm moving a lot slower. I'm really, really stiff in the morning. It takes me a bit before I can get into my shower. I have to get my coffee, and it takes me a much longer time to get out the door to go to work. By the time I get home from work, I'm very, very tired. I can barely make it through dinner. I have no energy for any other activities after work. I don't want to see anyone or go out to dinner. I just want to go home and go to bed. So this way you can see that from September to maybe December or January is just a few months. And that's what we call a rapid onset. So whereas with osteoarthritis, it is a very gradual, maybe over years, not this little span of a few months. So complaints of joint and muscle pain that evolves into joint pain with synovitis. And synovitis is inflammation of the synovial membrane that leads to the joint destruction and the deformity. So when that synovial membrane is worn away, what happens is, and sometimes you may hear doctors say this when he's talking to a patient, where it is bone on bone, the two bones in the knee perhaps are rubbing together. That means that there is no synovial membrane. There is no synovial fluid protecting those joints from rubbing together on each other. So if left untreated, this will lead to irreversible joint damage and disability because your client or your patient is going to be in a very, very great deal of pain. So some of these common joint deformities include a swan neck deformity, a boutonniere deformity, and then an ulnar deviation. And I did try and include some of these pictures in this PowerPoint, but when I tried to transfer them over from your textbook, which is where I found them, they did not transfer well at all. So, and if you may be able to bring these up online, or you may be able to just look in the textbook to see what these deformities look like. So some clinical manifestation, you might see rheumatoid nodules, and these are formed in subcutaneous tissue over bony prominences. Osteopenia, which is decreased bone density. If your client has ever gone to a DEXA scan and you are reading the DEXA scan report, that is what we are measuring in a DEXA scan. We are measuring bone density. They will complain of muscle weakness, episcleritis, and that is red and painful inflammation of the covering of the sclera, and there is no discharge. So the sclera of the eye, the whites of the eyes, it's going to be very red and very painful. And then there is the scleritis, which is the inflammation of the sclera, which will produce a very deep, very ocular pain, and this is quite agonizing for your client. So pleuritis. Pleuritis is an inflammation of the lining surrounding the lungs. You may see pleural effusions, which are excess fluid accumulations around the lungs. They may have pericarditis, which is inflammation of the fibrous lining that surrounds the heart. And they may have edema if you're looking at their, anemia. They may have anemia if you are looking at their lab studies. So how do we diagnose this? What will doctor do? Well, diagnosis is a process that may involve more than one evaluation by a rheumatologist. So there's going to be more than one opinion or more than one visit. It is diagnosed by combining signs, symptoms, lab values, radiology graphs, and ultrasound. So x-rays, ultrasound, lab studies, all of this, and then the clinical manifestations of the client, and that's how doctor will make his diagnosis. And according to the Arthritis Foundation, I believe, criteria has been updated so that we can diagnose RA at an earlier age. Because again, remember, we cannot cure this, but we can prevent further damage through medication and through exercise, through proper nutrition. We can prevent further damage, and we can manage the disorder. So by being able to diagnose this at an earlier age, say earlier than 30s to 50s, we may be able to save the client some discomfort and give them more longevity and more function of those joints. So diagnosis is based on symptoms that persist for 6 weeks or longer. 6 weeks or longer is consistent with RA. And so if you think back to my example where you are seeing somebody in the office or in the clinic in September, and then she has the same complaints, or the complaints have intensified in December or January, you can see that that is a longer time frame than 6 weeks. Patients will present with peripheral joint pain that is symmetrical, and they will complain of morning stiffness that lasts greater than 30 minutes. So again, someone who can get up and get themselves into the shower and get themselves out the door, of course, considering that they may not have children, in an hour and get themselves to work, that is not this person. But if this person gets out of bed and they need that 30 minutes to resolve that stiffness, they need to move about the house a bit, they need to have their shower, then sit for a bit, have their coffee, then sit for a bit, then yes, this is somebody who probably has RA. And then there is synovitis, and that may be detected by ultrasound. So, laboratory testing. Laboratory testing alone is not enough to diagnose RA. 25 to 30% of patients are negative for these antibodies. So a positive rheumatoid factor does not always indicate the presence of RA. So now we have to look at the C-reactive protein and the ESR, the sedimentation rate. These may be used to detect inflammation, but these will not be specific to RA. So, and you may have realized this when you were in the clinical setting and you're looking at your patient's labs. They might have a C-reactive protein that's elevated. They might have a sed rate that's elevated. And all this means is that there is an inflammatory process going on somewhere in the body. So these two lab studies alone is not enough for RA. However, this elevated CRP and ESR is an indicator that can be useful in distinguishing inflammatory arthritis from non-inflammatory arthritis. So if this sed rate and the CRP is elevated, then we know that it's an inflammatory process versus a non-inflammatory arthritis such as OA. So obtaining information regarding renal and hepatic function is necessary before initiating therapy as many medications can be toxic to the kidneys and the liver. And we remember this, right, from my last lecture and when we were talking about the kidney and the liver and the pancreas. These organs are going to filter these medications. And these medications can be very, very toxic. They're very helpful to the joint, but they're very toxic to the body and to the filtering process. So before we start any medications, doctor is going to want to know what is the kidney function and what is the liver function and is it within the norm. So baseline complete blood counts are necessary because anti-rheumatic medications may cause cytopenias. So there may be thrombocytopenia, which is a reduced number of platelets, leukocytopenia, which is a reduced number of white blood cells, and then anemia, which is the reduced number of red blood cells. So, and then before beginning a biologic therapy, a TB test and a hepatitis test will be performed as they have the potential to reactivate dormant infections. These biologics, and we'll talk about them in a bit, have the possibility of reactivating these infections that the patient has had and perhaps recovered from or may still be dealing with. So radiology, what are we going to do? Conventional x-rays are used to assess for bony erosions and joint space narrowing. And again, when you're looking at these x-rays, you will be able to see the disconnect between the bones and the joints. These x-rays are going to be repeated during treatment to assess for disease progression and drug efficacy. So we need to know, once we start a patient on a medication, doctor is going to need to know, is this medication working? And sometimes the only way we know that is to do serial x-rays so that we can know that the joint progression is not happening. MRI may detect erosions not seen on an x-ray. And for those patients who decline an x-ray or an ultrasound, if they decline an MRI, we will do an ultrasound. Sorry, I apologize. So non-pharmacological therapy. Education is the most important thing in this patient's management. They need education. They're going to need education on energy conservation. They're going to need education about range of motion exercises, aerobic exercises. Now, when I'm talking about aerobic exercises, I'm not talking about Zumba, and I'm not talking about, going out there and doing a class that is going to have a huge impact on these joints. Walking, swimming, best exercises for this population. Physical and occupational therapies. They're going to need nutritional support because there are some foods, sugars, carbs, anything white will anger and inflame these joints. So they're going to need nutritional support to think about making changes in their diet. And then rest periods. They need to be taught energy conservation, when to rest, when to get their chores done. Do they have more energy in the day, early in the day after their morning stiffness has resolved? Do they have more energy early in the day, and can they move about and then get all their chores done, run all their errands, and then they can rest for the larger period of the day? This is also true of the family members. These are people where you want to give them the ability to delegate a household chore to someone else. Can the daughter throw in the laundry? Can the husband start the dinner? So if this is a working client, when she gets home from work, she might be able to rest a bit before she needs to deal with anything that she may have to deal with for the evening time. But delegating household chores is something that you want to talk to her about or him about, and you want to include the family in this so that they understand the reason for her taking her rest periods. So the goal is to control the inflammation that leads to joint and tissue destruction, decreasing joint pain, synovitis, and stiffness, as well as maintaining joint function and preventing further joint destruction. Remember, we are not going to fix this. We cannot cure it, but we can maintain what they have and prevent further damage. So initial treatments are going to be analgesics, then the NSAIDs, and then the glucose steroids. So glucose steroids may be given PO, IM, intra-articularly. They may be given right into the joint, which in itself is very painful, or they may be given IV. And these will suppress inflammation and they will alter the disease process. However, these are not safe at high doses over long periods of time. So these medications, when doctor says, okay, we've taken down the inflammation, now we're not just going to take this medication away, because we can't just take away a steroid. When you're on a steroid, you need to be weaned off. That dose needs to be tapered down, and you need to be weaned off. And one of the things that you will instruct your client to do is to take this medication at the same time every day. And the best way to do that is to tie it to an activity. After I get out of the shower, I'm going to take my medication. While I'm having my coffee, I'm going to take my medication. After I brush my teeth, I am going to take my medication. So if they tie it to an activity, they are more likely to remember it. But it is most important that these steroids, these medications, be taken at the same time every day. Please take note of this. If we were in class together, this is something that I would probably drone on even longer about and ask you to repeat 3 times. So please do me a favor, do you a favor, and please take note of this for at least 3 times. So patients who do not respond to a combination of analgesics, anti-inflammatory agents, and low-dose steroids are treated with disease-modifying anti-rheumatic drugs, and these are called DMARDs. So some DMARDs are methotrexate, Arava, Plaquenil. Plaquenil is very present in the news right now. It was one of the possible medications for this COVID-19, but I think we went to Remdesivir. Azolpidine and Xeljanz. These are all considered DMARDs. Many patients will respond well to methotrexate, which is the first line of choice in the DMARD category. So methotrexate is taken once a week. It can be taken PO, it can be taken sub-Q, or it can be taken IM. And then traditionally, patients will move on to additional or alternative medications if methotrexate alone does not control the disease. So your client may be on methotrexate, and then if he takes his methotrexate on a Sunday or a Monday, maybe by Wednesday or Thursday, he may find that it's getting later in the week and he may need to take an NSAID or take an analgesic just to keep himself comfortable. And then the biologics. Over the last decade, medications known as biologics, and these are genetically engineered medications made from living organisms and proteins that have been approved by the Food and Drug Administration to treat RA, to treat rheumatoid arthritis. So these medications have proven to be beneficial in slowing or halting the progression of RA. But again, we need to be cautious about TB tests or hepatitis. And approved biologics may be given IV or sub-Q. Some complications will be of RA. Complications of RA are decreased function of joints. Those joints are not going to work as well. They're not going to have the range of motion. Permanent joint deformities, permanent disabilities. If we are not able to halt the progression of the disease, what will happen is that the disease will progress, and then your patient will become disabled due to this disorder. There is a risk for infection and an increased risk for developing cancer. So, assessment. Some clinical manifestations that we will see is an unsteady gait, bony enlargement or swelling of the affected joint or joints, maybe warm, maybe red. It will be painful. It will be a painful range of motion. Increased incidence of infection. because remember, their immune system may be affected, and they may have an elevated serum creatinine that is secondary to NSAID use. So that means that these NSAIDs that they're taking to control their symptoms, control their pain, is now starting to affect their kidneys. We will see elevated liver enzymes secondary to the methotrexate. Remember that the liver is, one of the liver's function is to filter medications. We may see constipation secondary to decreased physical activity. They're not up and around, they're not moving as much, so there may be some constipation, or because of the analgesics that they're using to control their pain. They may have nausea, they may have some oral ulcers that are also related to methotrexate use. They may have a cough or shortness of breath due to interstitial lung disease, which can be caused either by the RA or by the methotrexate therapy. So again, with these DMARDs, it does serve a great purpose because they're very, very helpful in treating and halting the progression of the disease, but sometimes it can take quite a toll on other parts of the body. So we will also assess their self-care deficit. Can they, are they safe in the shower? Are they safe in the bathtub? Can they dress themselves? Are they having trouble dressing themselves? Are they struggling with buttons or zippers? Are they struggling to tie their shoes? These are all self-care deficits. And we're going to monitor their fatigue. Again, rest periods and delegation of chores is very, very important for this population. Some nursing diagnoses: pain related to disease process, ineffective sleep patterns related to their pain, and then a self-care deficit related to decreased range of motion. We are going to look at our nursing interventions, our nursing actions. We are going to administer analgesics and anti-inflammatories as doctor orders. We are going to administer steroids as doctor orders. And now remember, these steroids need to be taken at the same time every day. And they cannot abruptly stop taking this steroid. This dose is going to have to be tapered. This is a medication that they need to be weaned off of. We are going to administer those DMARDs as doctor orders. And if they are on a biologic, we are going to administer the biologic as doctor orders. Then patient education. We are going to relay to them the importance of adhering to this treatment plan. They need to maintain their treatment plan to get the optimum result from their medications. Maybe some range of motion is in their treatment plan, so maybe they need to do some walking every day. Maybe they need to do some stretching every day. Maybe they needed nutritional support, and if they are to be removing some foods from or avoiding some foods in their diet in order to decrease the inflammation in their joints, are they adhering to that? They need to know signs and symptoms that they need to report to doctor: a fever, reddened areas, increase in joint pain. Immunosuppressive therapy should be discontinued when patients have an active infection. So we cannot continue to give them some of these medications if there is an active infection present in their body. And we will assist with referrals to an infectious disease specialist with chronic or atypical infections. So the rheumatologist and the infectious disease specialist, they will work very closely for the proper medications and the proper dosages, and in caring, they will co-manage the care for this population. So in order to keep the infections under control so that they can continue to take the medications that they need to take to halt the progression of their disorder. We will keep them current with their vaccinations. However, for this population, we do not recommend a live vaccine. So for this population, there will be no live vaccines, and we will refer them to physical and occupational therapies as needed. Again, because there may be an easier way, or there may be some equipment that they can use in the home to make their task easier. Then maybe there may be some range of motion exercises, some stretching exercises that they can do to help control their pain and maintain their range of motion and their movement. So assessment, again, we are going to assess. We are going to administer medications as doctor orders. We are going to talk to them about, again, adhering to the treatment plan, reporting signs and symptoms of infection. We are going to encourage compliance with vaccinations, and do they need to see physical and occupational therapy as well? So, scleroderma. Moving on to scleroderma. Scleroderma is estimated to be 9 to 19 cases per million per year. The usual age of onset is 30 to 50 years. The age of onset for women ranges from 15 to 40, so this is something that can happen to them in their teen years. Risk for developing scleroderma declines after menopause. How lucky for us. And the prevalence in women exceeds the prevalence in men by a ratio of 3 to 5. Scleroderma is not a hereditary disease, but patients with a first-degree relative with the disease has a greater risk. So again, the possibility exists that although this is not hereditary, it will travel in families. Environmental exposure, such as infectious agents, may play a role in triggering the disease. Again, there will be a trigger. So there's two main categories with scleroderma. There is the localized. And localized is isolated patches of hardened skin. So over various parts of their body, they will have, they will feel normal, the skin will be soft. But then there will be some areas of their body that the skin will be so hard. If you were to knock on a wall, that's what it's going to feel like. That's what it's going to sound like. Then there is linear scleroderma, and these are lines of thickened skin that will affect the tissues beneath. And so scleroderma and coupe de sévère is thickened skin on the head. And you may see this, you may have seen this if you think way, way back to the days when you were in the nursing home, semester number 1, and you were caring for the elderly, and maybe you have like a gentleman, or maybe you have an elderly woman, and you're helping her brush her hair, or you're helping them wash up, and you notice that they have these patches of hard skin on their scalp. That's what this is. And localized scleroderma typically does not affect internal organs. So now systemic scleroderma is much more serious and much more complex. It is divided into two categories of its own, and that is limited and diffuse. And it will involve not only the skin, but internal organs as well. So sometimes this disease can be fatal. There is a much poorer prognosis with systemic scleroderma than with localized. So some clinical manifestations. You may see diffuse or limited systemic sclerosis, which involve the skin, the lungs, the heart, the kidneys, and then the musculoskeletal system. On the skin, you will see patches of thickened skin, sometimes accompanied by itching in the early stages. Pulmonary-wise, they will be short of breath. There will be a non-productive cough. They may have pulmonary fibrosis, and there may be an increased risk of lung cancer. Cardiac-wise, you will see pericarditis, pericardial infusion, myocardial fibrosis. They will go into heart failure. They may have arrhythmias. Kidney-wise, you will see proteinuria. You will see impaired renal function. In the musculoskeletal system, you will see swelling of the hands. They will complain of joint pain, muscle pain, and incredible fatigue. So important manifestations of systemic sclerosis would be Raynaud's phenomenon, scleroderma renal crisis, pulmonary hypertension, and all of this is due to the abnormal vasoconstriction of the small vessels as a result of functional changes in the arteries. Remember, this is systemic. So mild renal dysfunction is common. Scleroderma renal crisis occurs in approximately 10 to 20% of patients with diffuse systemic scleroderma. It is rare in those with limited form. What does this mean? Well, this means that if your client has localized or limited scleroderma, then their kidneys may remain fine or only mildly dysfunctional. Whereas if this is more systemic, diffuse systemic, it will involve the kidneys on a much larger scale. It is characterized by sudden onset of severe hypertension, proteinuria, and progressive renal failure. So for that reason, morbidity and mortality rates are very high. Pulmonary artery hypertension. Symptoms will develop subtly over time. There may be generalized weakness on exertion, and then shortness of breath will develop later. Pulmonary disease is the leading cause of death in systemic scleroderma patients. Pulmonary disease is the leading cause of death in patients with systemic scleroderma. How do we diagnose this? What is doctor going to do? Diagnosis is supported by the presence of clinical manifestations and serum antibodies. Laboratory testing may confirm diagnosis, but not exclude it. So again, looking at lab studies, we will see that the possibility exists, but we can't confirm it. But we can't rule it out either. So common lab testing includes anti-nuclear antibodies, an ANA screening, and then depending on that lab result, doctor will test for more specific antibodies. More than 95% of patients will have at least one antibody present. X-rays may reveal subcutaneous calcification, distal esophageal hypomotility, and pulmonary fibrosis. Pulmonary function tests are important to assess the vital lung capacity and lung compliance. And then EKGs should be done routinely to assess for pulmonary artery hypertension and myocardial involvement. So we are looking at X-rays. Doctor is going to look at X-rays because we want to see calcifications. We want to know what's going on with the esophagus because remember, if there's something wrong with the esophagus, then there's the possibility of aspiration pneumonia, pulmonary fibrosis. Then we're going to look at the pulmonary function tests. What are their lungs like? How much function do they really have? And then we are going to look at EKGs to be able to look at their cardiac status. So before treatment is initiated, bronchoalveolar lavage and right heart catheterization to diagnose interstitial lung disease. Okay, so these are two things that doctor is going to want to do before we move into medications. Why? Because we need to look at those lungs and we need to look at that heart because we want to make sure all is well before we start them on these medications. Kidney biopsies to diagnose renal disease. In my personal practice and in dealing with these patients, I have never seen a doctor do a kidney biopsy to diagnose renal disease. Usually, doctor will just look at kidney function tests, the BUN, the creatinine. He may do an ultrasound to look at the kidneys, but I have, in my personal practice, I have never seen a doctor do a kidney biopsy. There is no single treatment to manage scleroderma. So treatment is focused on the specific organ involved and the clinical manifestations. So this means that it's kind of sort of like going to a restaurant that's a la carte. You get to pick and choose, right? So this is what doctor is going to do here. Treatment is going to be focused on the symptoms that your client presents with, the clinical manifestations, and if there is such an organ that's involved. So systemic steroids to suppress the immune response, antihistamines to alleviate pruritus, and that is the itching of the skin, and then topical ointments and moisturizers to help soften skin and to assist with the itching. Vasodilators. Vasodilators will improve circulation. We will use vasodilators to treat Raynaud's phenomenon, to treat pulmonary hypertension, and to treat renal impairment. Complications. Complications will be infection, if they go into renal failure, if they go into heart failure, if they develop pulmonary fibrosis, and then of course there is the possibility of death. So nursing management, we are going to assess, go back, reassess, we're going to assess again, we are going to administer medications as ordered, we are going to recommend range of motion exercises, we are going to assist in referring patients to a pulmonologist, a gastroenterologist, physical therapist as needed, and also to refer them to counseling as needed. Remember, this is happening predominantly in women, right? And at the very beginning, we said that the age range could begin as early as 15. So we are dealing with teenagers. And if we know anything about teenagers, we know that it's all about body image. But it's not only about teenagers and body image. These are women. These may be women who are dating. These may be women who are married and involved in relationships. They may have significant others. So body image and talking to them about their body image and them being able to discuss their body image issues, not only with us, nursing, and not only with the healthcare provider, but they need to be able to have those conversations with their significant others. So that is how we know that they are in acceptance of their disease, when they can share this information with others. Because remember, with their significant others, because remember, this is happening to women predominantly, and this is happening to them in childbearing years, starting from 15 up to age 40. So these are the times when we're involved in those intimate relationships. So they need to be able to discuss their body image issues. Patient education will include education on the disease process and how to protect their skin integrity. Because remember, those hardened areas of skin on their body, they need to know how to protect those areas. They need to know how to use the topicals. They need to know how to care for that skin. Also, if that skin becomes damaged, when that skin is hard, it's hard as a brick, it's as hard as a wall, they may not be always able to feel skin damage. So they need to know how to protect themselves. We need to talk about maintaining stable cardiac, pulmonary, and renal function. That is the goal of treatment. So care is going to be focused on monitoring, preventing, and managing complications of this disorder. So lupus, systemic lupus erythematosus, SLE, affects fewer than 25 people per 100,000. So not very common. The female to male ratio in children affected by SLE is 3 to 1, but it is as high as 15 for 1 for children, again, during childbearing years. So the age of onset varies according to gender and ethnicity. 65% of patients are diagnosed between the ages of 16 to 55. So again, here we are in those teenage years. We're beginning in those teenage years, age 16, going through age 55. So people who have relatives with SLE are at a higher risk than the general population for developing the disease. So again, this tells me that it lives in families. It will travel in families. Genes have been identified that predispose patients to SLE. The butterfly rash over the nose and the cheeks is a classic sign. The butterfly rash over the nose and the cheeks is a classic sign. And lupus is exacerbated by pregnancy due to the rise of estrogen. Please, ladies and gentlemen, you will remember these 2 facts. The butterfly rash over the nose and the cheeks is a classic sign. It is exacerbated by pregnancy due to the rise of estrogen. So, diagnosis is a complicated process in most patients unless they present with compelling evidence of clinical manifestations and then supporting labs. And one of the other things that will contribute to diagnosis is if there is a family member that also has lupus. 4 of 11 criteria must be present to support the diagnosis. There is a table in your book in chapter 19. Please refer to that table. Now that table again is in my book. It is in the old book. If you have the new book, then you're going to have to find the table on your own. I'm very sorry. But in my book, it is on page 356. There is no specific test for diagnosis. Lab findings are used to support or confirm diagnosis when combined with patient history and then the physical exam. So a lot of things, there's a lot of puzzle pieces that will go into this diagnosis of lupus. Lab testing is used to confirm the presence of autoantibodies. Specifically, SLE patients will produce ANAs, which confirm the presence of an autoimmune disease. Lupus is an autoimmune disease. So the presence of ANAs does not confirm the diagnosis of SLE, as 2% of healthy individuals are positive for ANAs. So again, this is not something that will confirm or deny. So lab testings, what are we going to do? There's other lab values that are important in diagnosing and treating SLE. So doctor will do a CBC, a complete blood count. Leukopenia may be present. Leukopenia is a decrease in the white blood cells. Thrombocytopenia may be present, which is decreased platelets. And then anemia, which are decreased red blood cells. We are going to do a UA, a urinalysis, with random and protein and creatinine levels. So doctor is going to look at the urine. We're going to look at serum creatinine and BUN levels. So we're looking at kidney function. And then again, we are looking at the C-reactive protein and the ESR levels to identify inflammation. So remember back when we were talking about RA, and we were looking at the C-reactive protein and the ESR. And we said that an elevation in these levels represented an inflammatory process going on somewhere in the body. So imaging is not used to diagnose SLE. It is not used to diagnose. However, Doctor will do radiology tests, and the more common ones are on page 357. So please take a look at that table. Please take a look at that common imaging result table. So non-pharmacological therapy. They need to avoid prolonged sun exposure, and they need to use sunscreen and SPF of 50 or higher, and they need to use it daily. Why? Because of the butterfly rash over the nose and the cheeks. They need to eat a well-balanced diet because, again, this is an autoimmune disease, so we want to make sure that they're not ingesting anything that will initiate the inflammatory process. Sugars, carbs, anything that's white. Again, this is another population that will need frequent rest periods and a regular sleep schedule because they will be very, very tired. They will complain of fatigue. They also need regular exercise to improve strength and maintain range of motion and a healthy weight. So again, walking daily, range of motion exercises daily, stretching exercises daily will work to assist this population. So pharmacological therapy is based on disease manifestations. Remember, we said we are just going to treat the manifestations as they occur. Anti-malarial medications, hydroxychloroquine with Plaquenil, impairs the antigen-antibody reactions, and again, this is why it was considered for COVID-19. However, with this medication, there is a concern for retinal toxicity and irreversible blindness. So we need to be careful with this medication. It is a very, very potent medication. Non-steroidal anti-inflammatory medications such as ibuprofen will treat arthralgias, myalgias, headaches, and fever. So again, we are going to treat the manifestations as they occur. And then steroids, the glucocorticosteroids, to suppress inflammation in joints, kidneys, and other organ systems. And again, these steroids are not medications that can be stopped abruptly. They need to be weaned. There need to be a tapered dose. Immunosuppressive agents, methotrexate, again, to treat joint inflammation, non-responding to non-steroidal anti-inflammatories or the steroids. So again, for this population, we can also look at those DMARDs and also biologics. Benlysta was approved in 2011. It was the first new treatment approved in more than 40 years. It will interfere with inflammation, decreasing immune response that causes clinical manifestations. Because again, we are going to treat these manifestations as they occur. Complications. Complications: renal failure, premature heart disease, interstitial lung disease, hypercoagulation. They may have a stroke, a vascular necrosis of joints. There is an increased risk for infection for this population. So they need to avoid potential situations. This is, I know that we're all avoiding these potential situations now. We are all avoiding crowds right now. But if we were back to the norm, this is not someone that you could take to a baseball game. This is not someone that you could take to a very crowded place. This is someone that needs to avoid any place where there is going to be large crowds. They need to be in the more isolated areas because of the increased risk of infection. We want to avoid the potential situations where they could contract something. So toxicities related to pharmacological therapy. Again, the kidneys and the liver are filtering these medications, so we need to be very, very careful. We need to look and monitor kidney function and liver function. So assessment, what are we going to do? We're going to assess. And then we're going to administer medications. Now, these medications are very cytotoxic. And again, look at the population that we are dealing with. We are dealing with a population of 15 or 16 to 55, which are childbearing years, predominantly childbearing years. Not someone who's in closer to their 50s, but someone's in the teenage years, early 20s, they're going to be thinking about having children. So we need to instruct these patients on the use of contraceptives to avoid pregnancy, especially while they're taking these medications, because these medications will cause birth defects. So we need to talk to them about contraceptives. They need patient education about the disease process. They need to know to use sunscreen daily, every day. Rainy days, cloudy days, they need to use sunscreen. They need to be up to date with their immunizations, but again, for this population, no live vaccines. No live vaccines. This is also a population that we need to talk to about energy conservation, taking frequent rest periods because of their fatigue. We want them to also avoid oral contraceptives because this population is very prone to migraines. So, and if you're a woman, you know that sometimes when you're taking a contraceptive or using an oral contraceptive, that it will contribute to migraines. And we can assist with referrals to pulmonology, nephrology, neurology, and then the cardiologist, because we need to look and maintain all of these systems in order to keep this patient well and healthy as can be.